Good evening, ladies and gentlemen. Welcome to episode 26, Secrets of Neurology. And today we bring to you two interesting case studies from the well-esteemed team of Sri Chitra.
So, is the volume a bit low?
Sri Chitra Institute of Medical Science.
Sorry, your voice is very low.
Okay. Is it better now? Is it better now?
It's better.
Yeah.
Okay. A warm welcome to our program director, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan. Thank you for bringing in all those pearls for so many months together. We would have two interesting cases and we would close it by 9:30 today. Our program director, to whom we are very, very grateful, Dr. Sudhir Shah, Professor and Head Department of NHL MMC, Ahmedabad, and sir is also Director of Neuroscience, Sterling Hospital, Ahmedabad, author of several books conferred with most prestigious Padam Shri for his work towards society and patients at large, and recipient of B.C. Roy Award. And also a warm welcome to our program director, Dr. Lakshmi Narasimhan, sir, Director and Professor, Institute of Neurology, Madras Medical College, recipient of various awards, including Paltussi Advisor from May I request Dr. Sudhir Shah, sir, to take it forward despite his busy schedule.
Thank you. Thank you very much, Dr. Manoj. Thank you. Whole team of Globusel Intouch headed by Mr. Chadda, Dr. Haley and others. At the outset, I would like to appreciate your sincere efforts in continuing this most wonderful, credible knowledge series, Secrets of Neurology. And I've been receiving lots of messages, emails, phones, and personal communications from all neurologists across the country, be it the senior professors or head of departments or students or junior neurologists. I'm thankful to all those neurologists who are regularly or intermittently attending this wonderful knowledge feast. And in this series, as you know, this is the 26th episode, and hello, yeah, this is 26th episode, and we are having today Dr. Shalja and her team. May I have the slide sharing, please? Yes. So this is the institute today, as you know, is one of the most reputed institute of India, Sri Chitra Tirunal Institute of Medical Sciences and Technology, so-called as SCTIMST. And the student who is going to present, one is Dr. Manisha KY, is a senior resident in neurology, and the second case will be presented by another senior resident, Dr. S.M. Krishna Mohan. So both the students would deliberate two different cases of obviously vascular neurology, because Shalja is heading the stroke and cerebrovascular disease. Next slide, please. After the presentation of the case, the whole dissection would be done by the postdoctoral fellow stroke, Sri Chitra General Hospital, Dr. Naveen Kumar. I am sure localization and differential diagnosis and etiology of, very unusual and wonderful cases will be done by him properly. And then, of course, next slide, please. As usual, the chief would take over, and she is none other than our Professor Dr. P.N. Shalja. How to describe her in a short time, but you know that she is a lady of too many accolades with very humble and noble character. She's a professor of neurology in charge comprehensive stroke care program, Smiths, Trivandrum. And she had 120 and publications and 8 book chapters, and did stroke fellowship from University of Calgary in 2006. Past president of Indian Stroke Association, honorary clinical professor, University of Lancashire, UK, member representing India, educational committee of the organization of World Stroke, WSO, membership committee of the European Stroke Organization, technical consultant of stroke care activities, Government of Kerala, member of the task force group of the non-communicable disease division of ICMR, member of GBD cardiovascular diseases, and PI of a number of international clinical trials. Recently, she has been on the board of director of WSO. We know that, and many congratulations for that, Shalja. And
Thank
her
you, sir.
interest, yeah, it's a matter of great pride for all Indian neurologists that you and Arvind and others have been on the board of the directors. So this is our voice will be heard even better than before, and it is very apt for you, frankly. So her interest in stroke is TIA, multimodal imaging, thrombolysis, intracranial atherosclerosis, stroke rehabilitation, all so many other things. So she's a very wonderful speaker with a lot of clarity of thoughts when she deliberates a talk. I can go on and on, but there is a restriction of time, and I'm sure we allow her to speak and listen to her dissection of different cases and how analytically she comes at the final diagnosis, the process of diagnosis, everything she will unfold. So thank you very much to all the delegates for your continuous inspiratory presence, and thanks for your wonderful feedbacks and comments. I must thank my co-chair, Dr. Lakshmi Narasimhan, a wonderful personality with tremendous knowledge, and his effort in helping me out in this series is also commendable. Once again, thanks to all of you. And for today's presentation, I must thank Shalja and her team. Thank you very much. Please take over, Dr. Shalja, from here. I'm sure your cases would have unusually brilliant diagnosis.
Thank you, sir. Thank you for those kind words, and it's so great to hear these words from you.
You deserve much more, Shalja, frankly, honestly.
And thank you to Mr. Arun Chada and team, and Dr. Manoj Kumar. I think it's a wonderful event, educational event we have from you. And I'm sure all the delegates, and we are also going to learn. It's not it's a combined learning of all of us together. And without wasting time, we have got 2 interesting cases for today. One is an acute case. Why we took an acute case? There is not much of a challenge in the diagnosis in the first case, but we just wanted to take the delegates through the process of what are all the advances that has happened, and how in the acute phase we can go into the clinical along with the imaging, and finally make your plan of prognosis and the management. The second case is in fact a significant and difficult case of that is also a case of stroke with cognitive decline, which will be dealt with Dr. Krishna Mohan. Both Dr. Manisha and Dr. Krishna Mohan are second-year residents. Both are on both of them are very good in their studies, and they have done a wonderful work of getting the whole case with the detailed imaging. And I think that's a good learning for them also. I think they have read extensively on that, more than me now. And Dr. Naveen will be going through the discussion, and at the end I will be adding further into the final diagnosis and management. So I think we won't waste time. Manisha, you can just go ahead presenting the first case.
Thank you, ma'am. Is my screen visible?
Yes.
Yes. I would like to go ahead with the first case for the day. It's a 39-year-old male patient who presented with acute onset weakness of right upper limb and lower limb since 11 a.m. on the day he presented to us, and facial deviation to left and slurring of speech. He's a 39-year-old male, right-handed, who works as a painter, not an alcoholic or smoker. He had past history of rheumatic heart disease with severe mitral stenosis, underwent balloon mitral valvolectomy in 2006. Along with that, he had atrial fibrillation, for which he was on anticoagulation. The last known dose was warfarin 3 mg, and the last checked INR was 1 month back. It was 2.4. He had no other risk factors, atherosclerotic risk factors like diabetes, hypertension, dyslipidemia, coronary artery disease, prior stroke, or TIA. His symptoms started at 11 a.m. on the day he presented to us with acute onset weakness of right upper and lower limb. He could not lift his upper limb completely on the right side, and he had difficulty with support to walk. He had facial deviation to left. Along with that, there was slurring of speech. His word output was preserved though, and he was able to understand what was spoken. There were no field cuts, blurring of vision, or drooping of eyelids or double vision. There was no chewing or swallowing difficulty, no sensory or bowel or bladder symptoms. There was no headache, vomiting, or seizures. His symptoms were maximum at onset and remained same without improvement or worsening until he presented at our hospital. So his symptoms started at 11 a.m. and he presented at 5:30 p.m. of the same day. That is 6 hours, 30 minutes after the onset of his symptoms. The most important thing we need to consider while taking the history of a stroke patient is the time of onset. Usually the type of onset we get from the bystanders is actually not the correct time of the actual onset of symptoms. So that's where the time last seen well comes into role while deciding on the modes of on the revascularization methods. It also helps us in deciding the window for thrombolysis versus mechanical thrombectomy. Especially this holds true in wake-up strokes and unwitnessed strokes. In case of wake-up stroke, usually when we consider the time of loss in well as the time when the patient goes to sleep. The another important point we need to consider is, along with asking when the patient goes to sleep, we have to ask whether the patient had woken up in the middle of the night and whether he was last seen normal at that point of time, because that also significantly alters the window for our revascularization. And again, in case of unwitnessed strokes, the patient last seen normal is considered as the onset rather than the onset told by the bystanders. Then, based on the history, we localize to the left MCA territory, whether it is a stem occlusion or branch occlusion, we cannot tell at this point of time with the limited history we have. And the vascular etiology in view of the acute presentation. And again, whether it is a ischemic or hemorrhagic, we decide based on a subset of symptoms. Like if the patient had significant headache with rapidly worsening symptoms, seizures, and altered sensorium, that favors a hemorrhagic etiology rather than ischemic. These symptoms were not seen in our patient. And the anticoagulation, as the patient is already on anticoagulation, with the INR, whether it is a suboptimal or elevated INR, we'll be able to subcategorize whether it is an ischemic or hemorrhagic stroke. And in view of the cardiac history of the patient without any other atherosclerotic risk factors, we consider embolic origin as the source of. Then coming to the examination in our patient had a heart rate of 63, irregular, and his blood pressure was 160/80. He had a mildly depressed sensorium with a GCS of 14. He had dysarthria with normal fluency, comprehension, repetition, naming, and reading. He had right complete hemianopia. There was gaze preference to left, which was overcome by oculocephalic maneuver. There was right UMN facial palsy, and he had right hemiparesis with an upper limb power of 0 and a lower limb power of 3. And there was right hemisensory dulling to all the sensory modalities. There was no ataxia or neglect, summing up a total NIHSS score of 15 out of 42. So after examination, we can localize based on the positive examination findings. That is the right hemiplegia, hemianesthesia, homonymous hemianopia, conjugate gaze palsy, dysarthria, without aphasia or apraxia, and a sum total of NIHs of 15. We can again localize to anterior circulation, MCA to the dominant side. And the points which favor it is a large vessel occlusion rather than branch occlusion is the presence of homonymous hemianopia, the conjugate gaze palsy, and the significant deficits in the form of a NIHS of 15. That is a severe stroke. And the etiology. the prior atrial fibrillation in the patient without atherosclerotic risk factors point the etiology towards a cardioembolic stroke. So that is our clinical localization after the history and examination. So the next important step is the blood investigations. Unless until the patient has other comorbidities, if the patient is an anticoagulation, the things we need to assess are the RBS at presentation and the INR at admission. The RBS was 140 in our patient, and the INR at admission was 1.42, which was a suboptimal anticoagulation, favoring our ischemic etiology rather than the hemorrhagic again. The only hematological parameter we need while assessing an immediate acute stroke patient who is an anticoagulation is INR, unless until the patient has other comorbidities. So if the INR is less than 1.7, and if the patient presents in window, we can take up the patient for thrombolysis, whereas more than 1.7 is usually contraindicated for thrombolysis. And while considering if the patient is a candidate for mechanical thrombectomy, we usually take up the patient for MT even though his INR is more than 3. However, there is an increased risk of symptomatic ICH if the INR is more than 3. So that has to be considered. So the next step after assessing the patient and doing the INR is to go for a imaging. The first thing is to do a non-contrast CT scan. A non-contrast CT scan is needed to rule out any hemorrhage in the patient and also to assess the early ischemic changes. So in our patient, this is the non-contrast CT. We are showing the axial cuts. The supraganglionic and ganglionic cuts both are needed to assess the aspects rather than taking a single cut. So in the ganglionic, we have to see at the level of caudate. Here we can see we have to compare the symptomatic versus the asymptomatic side. The symptomatic is left hemisphere. We can see that the caudate is normal, whereas the lentiform nucleus, which is
Manisha, it's better to show the next image. The third one, no, where the caudate can be seen better.
Yes, the caudate is clearly visible on the right side. On the left side also we do not have much difference, whereas the lentiform nucleus, which is clearly seen on the right side in an almond shape almost, is not seen clearly on the left, suggesting there is the involvement of lentiform nucleus. And insula, the insular margin, which is also clearly seen on the right side, is not seen again well defined on the left side. So there is involvement of lentiform nucleus, insula, and the internal capsule also. The posterior limb, which is clearly visible on the right, is not well defined or ill-defined on the left. So along with that, we have to see M1, M2, M3. M1 is normal. M2, as we can clearly see, is involved. There is difference in M1, M2 on the right and left. Left it is ill-defined. And M3 is normal. So in the ganglionic cuts, we got 3 areas. We got 4 areas actually. M2, the posterior limb of internal capsule, and the lentiform nucleus and insula. Then coming to the supraganglionic cuts. In the supraganglionic cuts, we need to assess M4, M5, and M6. M4 is normal, as you can see on both sides, whereas M5, we can see there is faint gray white matter differentiation compared to the right side. On the left side, it is faint. So M5 is also involved, whereas M6 is normal. So, we have 1 in supraganglionic, and in ganglionic, we have 4 involvement. So a total of 5. So subtracting, we get the CT aspects of 5 in our patient. So along with the CT aspects, we can see in the initial non-contrast CT, a hyperdense ICA and MCA sign. We can see a thrombus visible in the supraclinoid ICA, which is further extending to the proximal segment of MCA. So this is hyperdense ICA and MCA sign, suggesting that the thrombus is an RBC-rich thrombus and more amenable to revascularization methods, and also suggesting there is an underlying large vessel occlusion. So our patient with acute ischemic stroke with a significant deficits, NIHSS of 15, with a CT aspects of 5, and without any hemorrhage on CT, and presented within 6 hours, 30 minutes after the onset of symptoms. The patient is not a candidate for thrombolysis as he is out of window. The next step is, based on the hyperdense ICA and MCA sign, we also consider there is an underlying large vessel occlusion. So the next step is to go ahead with CT angiogram.
Thank you, Manisha. I will just like to take over from here. This is a multiphasic CT angiogram done in our institute. I have
Naveen, we cannot hear you very well.
Now is it audible?
Yes.
This is the multi-phase CT angiogram done at our institute. I have given two cuts actually. One is the coronal image of the patient and one is the sagittal image. So when we see on the left side, we are able to, on the right side, we can see the ICA clearly, whereas on the left, the ICA is not seen clearly. We are not able to see the flow in the left ICA. Even in the intracranial portion, the cavernous and the and the infracranial segment is not clearly seen, whereas the A1 segment of the ACA is seen, and the M1 segment of the MCA, there is a partial filling, and then the branches are well seen. When we look at the sagittal images of this patient, we can see that there is a long segment, gradual tapering of the ICA, and after the distal cervical ICA, from then onwards, we are not seeing it. So this is a pattern which is suggestive of a pseudo-occlusion. We already saw in the plain CT that the thrombus was visible in the distal ICA as well as the proximal MCA. So what is this pseudo-occlusion? Pseudo-occlusion is when there is an occlusion in the distal portion of the ICA and we are not able to find the flow in the ICA because of the presence of the distal clot, and the slow flow transits into a gradual contrast decline in that same ICA. So when we look at this CT angiogram image, we can see that there's a gradual tapering of the distal cervical ICA. So there are certain patterns of occlusion which can give us a clue to this. When we look at the CT angiography, there are three different types of abrupt cutoff of this ICA. One is this abrupt cutoff, where you can see the bifurcation of the ICA itself, the ICA is cut off. This is called the stump kind of an appearance. And then there is a spearhead kind of an appearance of the ICA, wherein we can see for about 2 to 3 centimeters, there is a spearhead shape of the ICA, and then it is not opacified. And then there's a streak type of appearance where we can see a gradual contrast decline extending up to the distal cervical ICA as seen in our patient. And intracranially, we can see 3 different occlusive patterns in the Willischian circle. One is the T-type occlusion, where the thrombus involves the distal ICA as well as the proximal A1 and M1 segments. This is the T occlusion. The L occlusion, the thrombus involves the distal ICA as well as the M1 MCA. And the I-type occlusion, which involves only the distal ICA with the patent flow of the A1 and M1 segments. So what is the importance of knowing all these patterns of ICA and in the patterns of angiographic occlusion is that it can give a clue as to where is the occlusion located. This study done by Hong et al. Was published in Medicare, and it was reported that the patients who are having the streak kind of an occlusion in the ICA, that is actually a pseudo occlusion, they were more likely to have the clot location in the carotid terminus. So, which is consistent with what we see in our patient also. Whereas the presence of a stump kind of an occlusion was more often associated with the occlusion at the level of the cervical ICA itself. Why we need to distinguish this type of patterns and we should know about it is the presence of a cervical ICA with the tandem M1 MCA occlusion as a 2B evidence recommendation for mechanical thrombectomy, which is not the same as one with the internal carotid artery, terminal ICA occlusion or a proximal M1 occlusion, where the chances of opening up the vessel is much higher than with the tandem occlusions. So it is better to know about these patterns of occlusion in CT angiography. Then we'll come, next information we gather from the multi-phase CTA is the collaterals. So collaterals is actually the filling of the vessels, which can be seen both in the pile as well as in the Willischian circle. So we do multi-phase CTA means 3 phases are used. One is the first, the arterial phase, the second is the capillary phase, and third is the venous phase. So based on these 3 phases, we'll get an idea about the arterial, capillary, and venous filling. So the first image on the left top is the normal filling of the right M1 MCA, whereas the left is the pathological side where M1 is occluded. We can see in the first phase, the arterial phase, there's a reduced filling, which is filling up well in the second phase, capillary phase. At the same time, the filling in the right side is reducing gradually, and the venous phase, it is completely almost it has washed out, whereas in the left side it is starting to wash out, but there's a 1 phase delay. So this is called good filling of the collaterals with 1 phase delay. The second type of collateral pattern which you will see is in a patient with the M1 occlusion on the left side, we can see that there is a pulling up of the contrast in the second phase, which is still present on the third phase, whereas the right side, the normal phase has completely washed out. So this is a kind of a delayed filling with the impaired washout, as we can see on the curves on the right. And the third is a patient with a poor collateral pattern, as seen in the section of C. where in all the three phases, the MCA pile collaterals are not filling completely. This is suggestive of a reduced extent. So there is a poor collateral which is not filling even in the third phase, which means that the amount of arterial contrast filling is reduced and it is remaining that's even in third phase. These are the patients with the poor collaterals. To give an idea of what is good, intermediate, and poor collaterals, here I have shown three different scans and three different phases of each of the scans. So in the first two, there's an M1-MC occlusion, the third on the left, and the third is a right M1-MC occlusion. We can see that in the first patient with the good collaterals, in the phase 1, compared to the right side, the left side is almost filling, except for some areas of paucity in the left M1 region. And in the second phase, the filling is as good as the normal side on the first phase. And in the third phase, it is starting to get washed out also. Whereas a person with the intermediate collaterals as shown in the second line, we can see there is a reduced filling as compared to the normal side on the first phase. But this filling is being compensated in phase 2. And in phase 3, we can see that the washout is there, but still pulling up of contrast is there. Compared to the poor collaterals in the third image, third row, we can see that in the right M1 MCA, after the occlusion, there is no filling, proper filling, even seen up to the third phase also. This is suggestive of a poor collateral. So the idea is the one patient with a good collaterals is more likely to have a smaller infarct value, higher chances of salvageable penumbra, and also the patient is more likely to benefit with DVT compared to those with the poor collaterals. And the ones with the poor collaterals are more likely to be rapid progressors, in that the volume of the infarct is destined to grow rapidly by the time they come present to us. So coming to our patient who are presented to us 6.5 hours after the onset of symptoms, we can see phase 1, phase 2, and phase 3. We have given 3 cuts at the level of the temporal lobe as well as the ganglionic and supraganglionic levels. In phase 1, we can see that the filling is less than the normal side on the right. But in phase 2, we can see that the filling is as good as on the right side. And in phase 3, there is a 1 phase delay with a mild pulling up of the contrast in the third phase. In the ganglionic and supraganglionic cuts also, we can see that in phase 1, the filling is reduced compared to the normal side on the right. But in phase 2, we can see it is better than the filling on the right. And in phase 3, there is an impaired washout. So this is suggestive of good collaterals in our patient with the left M1 occlusion. Next, we come other characteristics which we can assess in a multi-phase CT angiogram is a clot burden score. The clot burden score was developed to characterize the total burden which and the amount of clot which is there to be recanalized. So they have given 10 points for this clot burden. It is involving the infraclinoid and supraclinoid ICA. 1 point for the infraclinoid, 2 points for the supraclinoid ICA, 2 for each for the proximal and distal M1 MCA, 1 each for the M2 branches, and 1 for the A1 ACA segment branches. So total score will be 2. And in a CT angiogram, when you see the clot, that area will not be opacified. So you have to score for each of the segment that is affected and subtract it from the total of 10. Similar to aspects, you subtract the value which you get by seeing the clot from the total 10. That will be your clot burden score. Here we are not seeing the infraclinoid portion of the ICA. The supraclinoid portion is not seen. The A1 is seen and the proximal M1 MCA is not seen. Whereas the distal M1 MCA and the branches are seen. So 2 for the proximal M1, 2 for supraclinoid, 1 for infraclinoid. So 10 minus 5 will give a clot burden score of 5. It is important to know this because those with a clot burden score more than 6 are likely to have higher chances of recanalization with EVT. Another aspect is the thrombus length. The length of the clot which is measured will give an idea of the ease with which you can achieve recanalization with IVTP as well as with the EVT. Smaller than medium size clots require less passes and better chances of recanalization. Our patient had a long segment clot, 19 mm, but it was having a clot burden score of also of 5. The other factor which we have to look at is the thrombus permeability. Despite the clot being a long clot, our patient had a grade 2 permeability. So the permeability is graded as 0, 1, and 2 in CT angiogram source images, not the MIP images like this one. In source image, if you are finding an abrupt cutoff of the vessel and there is no difference between the thrombus as well as adjacent parenchyma, it is grade 0. Whereas if you are finding the thrombus is hyperdense than the adjacent parenchyma with minimal, with this kind of a difference, that is grade 1 permeability. Whereas grade 2 is when you can demonstrate a thin streak of flow across the clot with the proximal and distal vessel contrast HU being the same. That is more suggestive of grade 2. So clots with grade 1 or 2 permeability have about 5 greater chances of attaining recanalization. Our patient had a grade 2 permeability thrombus. So despite being a large thrombus, the permeability was very good.
So our imaging findings are: a CT angio showed occlusion of distal ICA with extension of thrombus to proximal M1 with good collaterals. And the thrombus location is another defining factor to assess the amenability with which recanalization can occur. Like the more proximal the clot is or thrombus is, the lesser the chances or the more difficult it is for the recanalization, either with thrombolysis or mechanical thrombectomy. That is, for example, if the clot is in distal arteries rather than the proximal ICA or proximal M1 MCA, then the distal arteries are the ones which are more amenable for revascularization. And the other important factor is that
Manisha, just a minute, because we should also mention that it's whenever the clot is in the more proximal area, the chances of amendability is mostly with regard to the ICA and the distal ICA.
Yes.
When it comes to more distal like M2 occlusions, then also it becomes difficult. So it's not easy.
Yes,
Okay.
yes, ma'am. Then in our patient, the cardioembolic origin also. The thrombus in cardioembolic origin patients are usually RBC rich, again, which are more amenable to revascularization. So along with that, as previously already told, the thrombi with grade 1 or grade 2 residual flow on CTA are again more amenable to revascularization. These are all the other factors we need to consider. So our patient presented at 6 hours, 30 minutes. So less than 6 hours is actually a sure shot thing we can take for MT, but 6 hours, 30 minutes constitute late window. So while selecting the patient, whether he's a category for late window mechanical thrombectomy, we saw 2 landmark trials which have assessed the late window selection criteria for MT, DEFUSE 3 and DAWN. The DEFUSE 3 have taken the time window up to 16 hours, whereas DAWN has taken the time window up to 24 hours.
I think we don't have to discuss that in detail, Manisha. Just briefly tell.
Yes, ma'am. And the significant important difference in between both the trials is the mismatch definition. Whereas DAWN has taken a clinical imaging mismatch definition, that is a patient with significant clinical characteristics, but with less amount of core on imaging. They have taken these patients as candidates for MT, whereas DEFUSE 3 have used imaging perfusion mismatch criteria, like with either CT perfusion or MR perfusion, the infarct core volume of less than 70 ml and a mismatch ratio of penumbra versus core of more than 1.8 were considered for MT. So these were the late window selection criteria. As per the recent AHA guidelines also, any patient presenting at 6 to 24 hours to us, and we have detected a large vessel occlusion with CT angio, we need to go ahead and do a perfusion imaging, either CT perfusion or diffusion weighted perfusion. In our center, we prefer CT perfusion because also it's a time saving procedure.
Thank you, Manisha. So coming to the definition of perfusion parameters, for a basic idea, we look at cerebral blood volume and cerebral blood flow. So volume is basically the amount of blood in a unit brain mass, that is 100 grams of brain, and a fraction of a voxel that contains the blood vessels, that is cerebral blood volume. Cerebral blood flow is defined as ml per 100 gram per minute. It is the volume of blood flowing through a unit brain mass during a unit of time. The thing is, with regard to ischemic core, both will be reduced. Both CBV and CBF will be reduced, but in cerebral penumbra, for characterizing penumbra, the CBF will be reduced, but the CBV will be increased. And all these other parameters like MTT, TTP, and Tmax, they look at the penumbra aspect. So coming in our institute, we don't have this automated image processing softwares like Rapid. So we usually use the visual impression of CBV versus CBF mismatch. This is the perfusion scan of our patient. We can see that the CBV and CBF, there was a significant mismatch both at the ganglionic and supraganglionic levels. The blue indicates that there is a reduced blood flow, and the CBV, you can see that this is a normal CBV in both the cuts, but we can see the mismatch between the CBV and CBF as seen in the ganglionic and supraganglionic levels in the left MCA territory. So our patient had a significant mismatch both by CBV as well as CBF.
So summing up the imaging findings in our patient, he had a CT aspects of 5 with a hyperdense left ICA MCA sign, and on CT angio, there was a left IC and proximal M1 occlusion. with good collaterals and a clot burden score of 5, and a clot length of 19.4 mm, which is a long clot, and thrombus permeability of grade 2, and a significant mismatch on CT perfusion. So the decision is whether to take the patient up for mechanical or not. The pros in our patient are that he's an young individual with disabling deficits with an NIHS of 15, and the patient had a dense ICA and MCA sign, which also indicates it's a RBC-rich thrombus, more amenable for MT, and a permeable clot, good collaterals, and a significant mismatch on CTP. All these are pros for mechanical thrombectomy, whereas the ones which are not in favor are the late window, 6 hours 30 minutes, and an aspects of 5, which is borderline aspects, and the long clot. However, finally, considering the amenability for MT and considering the age and pros, we have taken up the patient for mechanical thrombectomy. After explaining the risk of the procedure and the outcome to the bystanders, we have explained them that there is risk of symptomatic ICH after the procedure also. However, compared with the control population, the risk is almost negligible. This is the Hermes collaboration data, which showed that the symptomatic ICH is only 4.4% in intervention people compared to control. However, they have done a subgroup analysis of large core infarcts, like with aspects of less than 6. In this population, there was mildly increased symptomatic ICH risk to up to 9%. So our patient comes under the large core infarct. So with the mildly increased risk of symptomatic ICH, we have anyway went ahead with our MT. The door to groin puncture time was 58 minutes. Our patient underwent mechanical thrombectomy under conscious sedation. A stent retriever thrombectomy was done, attaining TICI grade 3 recanalization with just 2 passes. And the recanalization time, groin puncture to recanalization time, was 43 minutes. The immediate post-MT NIHSS was 6 in our patient. That has come down from an initial onset NIHS of 15. So the decision regarding the mode of anesthesia to be followed in mechanical thrombectomy. Conscious sedation was the modality we used in our patient. There is no clear consensus for general anesthesia versus conscious sedation. The trials have argued against general anesthesia. So far studies have argued against general anesthesia because the mechanisms proposed for poor functional outcome were the significant hypotension during the intro procedure and the delayed door to groin puncture, because of all the requirements for general anesthesia and the increased risk of symptomatic ICH. So considering all this, we have preferred conscious sedation in our patient rather than GA. Next, we went.
So this is the DSA image of a patient. So in DSA, we are able to see that the first left ICA injection, there's an occlusion at the left carotid terminus, and we are not able to see the M1 segment of the MCA. And we can see that the stent retriever is being passed here. It is being passed to the M1 segment. And this is the, after the successful mechanical thrombectomy, we are able to achieve a TICI-3 recanalization with a good flow notice both in the AP as well as lateral views. So after successful recanalization, you have to demonstrate the good flow in at least 2 lateral, both AP as well as lateral views. And we achieve TICI-3 recanalization. TICI is basically the grading used for assessing the recanalization status. This is divided into from 0 to 3. 0 is when there is a complete occlusion and no perfusion of the MCA territory. Here I'm telling MCA because M1 is occluded and it's not perfused at all in the DSA. And TICI-1 is minimal perfusion in one of the branches. TICI-2A is perfusion seen in less than 50% of the MCA territory. TICI-2B is perfusion seen in more than 50% of the MCA territory. And TICI-2C is near complete perfusion, except for some distal cortical emboli or slow flow noted in the MCA branches. And TICI-3 is complete perfusion of the occluded MCA territory. So this is a 24-hour scan of our patient. Manisha, you can proceed.
The 24-hour non-contrast CT we have done in our patient showed evolved infarcts in the again we have to see at the ganglionic and supraganglionic cuts. In the ganglionic level, we can see there is involvement of caudate along with that lentiform nucleus, insula, M2, and in the supraganglionic M5. So a CT aspects, 24-hour aspects also was 5. So we were able to salvage a lot of penumbra in our patient with the procedure. So the next important thing that comes is the post-mechanical thrombectomy care. One of the most important aspects we need to focus is on the blood pressure management. The AHA guidelines so far have shown that in any patient up to 24 hours after MT, a target of less than 180 by 105 is recommended. However, it's not a hard and fast rule. The management again will differ based on the amount of reperfusion attained in the patient. The recent studies have shown that a systolic blood pressure value higher than 160 millimeter Hg was associated with poor functional outcome and more risk of symptomatic ICH compared to less than 140 millimeters of Hg. So in our patient, we have considered a BP target of less than 130/80 during and for about 24 hours after the procedure. A 24-hour NIHSS was 3. And the 24-hour repeat CT, because there was no hemorrhagic transformation, we have initiated the patient on antiplatelets. The next thing that occurs, because ours is a cardioembolic stroke, the next question that arises is when to restart the anticoagulation. So this is the general consensus by European expert data, which has showed that the 1-3-6-12-day rule, based on the severity of the stroke and the timing or gradation of the days at which we have to start the anticoagulation. However, considering we also have to see the individual patient data. So in our patient, there is high risk of recurrent ischemic events in the immediate period after the stroke. So an early anticoagulation is warranted in our patient. So after mechanical thrombectomy, 48 hours later, we have done a repeat CT head, which showed no hemorrhagic transformation. So we went ahead with anticoagulation with warfarin. However, we need to rethink our decision sometimes if at all there is very large infarct or if there is hemorrhagic transformation. So based on that, it's not a hard and fast rule. So the follow-up of a patient at discharge, our patient had an NIHSS of 3, which was improved from an NIHSS of 15 at the onset, and the discharge MRS was 2. We have followed up the patient 3 months later. 3-month MRS was 2, and he had no recurrent vascular events during the intervening period, and his INR at 3-month follow-up was 2.6. So this is the algorithm of a patient. From an initial NIHSS of 15, we were able to get the discharge NIHSS to 3.
I think for want of time, Manisha, we will stop with this. That was a very good presentation of the case. And Dr. Naveen also with regard to the flow of how the case was presented. Few points which I would like to highlight before we open it up for questions for the delegates. One is the importance of imaging and the importance of finding out the time last seen normal, especially when it comes to ischemic stroke. There is now with advanced imaging, there are a lot of aspects which comes in, which will help you in your decision making. So most important is that with regard to the aspects, looking at the core, which has been clearly highlighted. And second, CT angiogram is a mandatory part of your evaluation when you have a patient with a large suspected large vessel occlusion. And the amount of information you get is significant, especially with regard to the collaterals. Please see that the collaterals. So if you have the same patient with a large core, like a 5 aspects, which is a large core, anything less than 6 is a large core. We can take up patients up to 4 and 5, depending upon the patient selection. We have to be very careful. But when you have aspects of 5, and if the same patient had a poor collateral, we are not going to take up this patient. So that is how the imaging is going to make your decision difference in your decision making. Third is, as Dr. Naveen has clearly highlighted, it is very important to know with regard to whether the ICA occlusion is from the cervical ICA with a distal M1 occlusion, where the endovascular procedure is going to be more difficult compared to a patient who is having a L occlusion or a T occlusion, versus a patient with a proximal M1 or mid M1 occlusion, where the recanalization rate is likely to be, or the recanalization success is going to be much better. And one more important point which was highlighted is the thrombus permeability, because if you have a very permeable thrombus, in fact, one of my fellow had also recently published, Dr. Hari, on the thrombus permeability, that in fact gives you a prediction regarding the chances of successful recanalization. You may need less number of passes. That only suggests it is a permeable thrombus. So even if you give a bridging thrombolysis for these patients, the chances of opening up the vessel is likely to be much better. So overall, we are getting a lot of information from the imaging, which not only helps in making a decision of treatment, but also it helps you in making the decision of whether this patient is likely to worsen after your treatment. I think now we can open any questions. Please suggest alternative to labetalol for IV management in a patient with bradycardia. Is NTG safe in raised ICT? Yes. So for that's a very good question. One point we need to understand is that labetalol is the only one which we have available as IV drug. Rest of the IV enalapril and nicardipine is not available in our setup. So if we have a patient who has got a contraindication for beta blockers, the only option we have is to give NTG. Currently, you are definitely safe in giving a NTG because in that acute phase, you are not going to expect any raised ICP at that point of time. So you can safely use NTG. We all use NTG for these patients. Why antiplatelets in cardiology?
Sorry to interrupt. Do you have injectable enalapril available at your center?
No, sir. No, sir. We don't have.
Okay. We have from a local company actually. Okay.
Okay, sir. Okay.
So how do you
So
find
if you have it, if you have that, definitely that is an option for the patient. But since we do not have it, we are usually using NTG itself, sir.
Okay, thank you.
Why antiplatelets in cardioembolic stroke? Oh, that is actually because it was just started the next day because we wanted to wait for 1 or 2 days more because antiplatelets is not a treatment for rheumatic heart disease with a cardioembolic stroke. The treatment is anticoagulation. So I think the antiplatelets was probably mentioned as a bridging before starting anticoagulation. Any other questions? If you do not have any questions, we can go to the target BP in ICH infarct post thrombolysis. Okay. So always if a patient has got a post thrombolysis bleed, whether it is whatever be the cause for the bleed, it is always better to keep the blood pressure low, especially below 140, because always a raised blood pressure increases the chances of hematoma expansion. Cost of MT. Cost of MT is currently, if you take the cost differs between whether the mechanical thrombectomy is done in a government setup versus it is done in a corporate hospital. It is very expensive. So because we do not have to pay for the MRP. So if you are doing it in a government setup, or especially in institutes like ours where we don't have to pay any MRP and we get it at a reduced price, even with that, our cost comes to 2.5 to 3 lakhs. Probably if it is done in a bigger corporate hospital, it may come to 4 to 4.5 lakhs. Definitely it is expensive, but one point we need to understand is that it is still cost effective even while taking the consideration of, and we have got a lot of evidence to suggest that how cost effective it is going to be. When do you prefer bridging therapy? Which is the TPA preferred, alteplase versus tenecteplase? Oh, that is a very good question. If a patient is coming within the 4.5 hours and the patient is a candidate for mechanical thrombectomy, the current data suggests that bridging is always better than direct MT. The systematic meta-analysis also shows that it is better to do bridging and then take up the patient for mechanical thrombectomy. I would, regarding tenecteplase versus alteplase, in a patient of bridging therapy, definitely there is data to suggest that we would also prefer to give tenecteplase. 2 or 3 reasons for that. One is, as you know, tenecteplase can be given as a bolus dose so that while taking the patient to the cath lab, it is very, very easy. Otherwise, you have to carry on with an infusion, which is going to be difficult. That is one. Second is if you are giving tenecteplase and shifting the patient to another comprehensive care center for mechanical thrombectomy, it is not easy to give alteplase and send. So tenecteplase is preferred. And also we have got data from the Bruce Campbell study showing that the recanalization rate with tenecteplase was definitely better compared to the alteplase. But we need to wait for more evidence to suggest that, and also from the ACT trial, the sub-analysis data we should wait for to see which would be better. But definitely for bridging, it is easier to give the bolus dose and shift the patient to the cath lab. And bridging therapy is currently preferred, but maybe in a select group, you may not consider bridging in that patients. For example, if you have a patient with a ICA, cervical IC occlusion with distal M1 occlusion, those are not the patients where the IV thrombolysis is going to be effective. There are all large clots where it is not going to be effective. You don't want to do bridging for that patient. Maybe in the borderline patients, for example, you have a large core thrombectomy patient where the bleed risk is going to be slightly higher. I would also prefer not to do bridging therapy in this patient, even if the patient comes within the 4.5 hours time limit. What is the time limit for us to look for hemorrhagic transformation? Is it 48 hours or more after thrombectomy? If the hemorrhagic transformation did occur, when we could start the anticoagulation. Okay, so the time limit, always the mandatory guideline would suggest that if a patient has not had any worsening, always it is preferred to do a 24-hour CT to look for any hemorrhagic transformation. But hemorrhagic transformation can occur even beyond 24 hours up to 48 hours. If a patient has got a hemorrhagic transformation, when do we start the anticoagulation? We cannot give a definite time period. That will depend upon two factors. One is the degree of the hemorrhagic transformation. You will be looking at whether it is a hemorrhagic infarction versus a parenchymal hematoma. If you have a patient who has got a parenchymal hematoma, that is a PH2 hemorrhagic transformation, in that patient, you are definitely going to wait for at least a period of 2 weeks to start the patient on anticoagulation. But if you have a HI1 hemorrhagic transformation, you can start, depending upon the volume of the infarct, you can start this patient within the first few days. But looking at the hemorrhagic transformation and deciding, you also need to look at the early risk of ischemic event in that patient. What if you are talking of a non-valvular atrial fibrillation? You may just wait for more period of time if you have a PH1 or PH2. But if you have a patient who has got a rheumatic heart disease or a LV thrombus, where the early ischemic event or a prosthetic valve, those patients you cannot wait for a longer period of time, especially in a prosthetic valve, you may not wait for a longer period, and you may start with a low dose anticoagulation and then increase the anticoagulation to a full dose. Why patient was not thrombolized based on the extent trial? Okay, very good question. Still, extent trial has not become a guideline now. We are still, you can definitely give IV thrombolysis in the extended time period for a select group of patients. But our patient definitely is not a candidate for an extended time window because we already know it is a large core thrombectomy, large core patient where the bleed risk is going to be very high. What is the place of tirobefan in mechanical thrombectomy? Tirobefan, there is no need to give tirobefan in our patients. There is a select group where we may be giving. For example, if you have a patient, for this, we have used in our patients is in situations where you have a intracranial atherosclerotic disease, where we have removed the thrombus, there is going to be reocclusion. And this happens in many of our ICAD patients, where there is reocclusion. And in these are the patients you may prefer to give tirobefan in our patients. When we start antiplatelets after with no IVT, when can we start after MT? We can start within the first few hours if you are not strongly suspecting, but when you are having a thrombectomy done, it is always better to wait for at least a minimum period of 12 to 24 hours and see the bleed risk and then start the patient on antiplatelet. We may start these patients very early in situations of an intracranial atherosclerotic disease where we have tried to open up the vessel, the patients had a TICI 2B or a TICI 2A. In those patients, the reocclusion risk is significantly high. In those patients, we load them early with antiplatelets. Whether MR diffusion overestimates the CT aspects. Now, if you are doing a MR diffusion alone, that may not be enough. You have to definitely, because MR diffusion is not going to be completely the core. So it's always better to look at the diffusion flare mismatch and make your decision. So if you have a MR diffusion and the flare showing no mismatch, definitely, then that would be the core itself. But it's all depends, Nikhil, on the chances of how good. It's not easy to do a CT aspects unless you get your eyes tuned to reading the CT aspects. And it is not easy to read the aspects. You have to really put in the stroke window, very carefully read the CT aspects. But we need not be bothered about 1 point less or so. That is not going to make a big difference. So I think an aspects of 6 versus 7, you're not going to make any big difference in your decision making. But if it becomes a larger core, probably you may have to make your decision by carefully looking at the diffusion. So if you are in an MR setting where you routinely do MR, just look at the MR diffusion and the flare and make your decision. What anticoagulant for a 67-year-old recurrent cardioembolic stroke with history of hemarthrosis on warfarin? Okay, very difficult decision. Probably the only option may be, depending upon in these patients, we may have to, if it is a non-valvular AF, you may have to consider other ways of treating these patients. We may have to go ahead and look for LA occluder and then make your decision of treating these patients. How long to give anticoagulant if there is an intracardiac clot like LV clot? That depends upon what is the etiology of the clot. If you have a patient who has got a clot and this patient has got a poor LV ejection fraction of less than 28%, that patient would require long-term anticoagulation. If it is an acute MI patient who is having a LV clot, that patient may require only. So it's going to be decided by the etiology of the cardiac clot. Indication of dual antiplatelet and time duration. Do we have time to go? Can we take the questions later? Because otherwise we may be not be able to. I think we'll come back to these questions because the case is going to take some time. So we'll definitely come back to all these questions after going through the second case, which is a very interesting case.
Anyway, it was a brilliant case and wonderful workup and very nicely explained by you and your team. Thank you very much, Shalja. Let's have the second case now.
Good evening, everyone. Am I audible?
Yes.
Today I'm going to present the second case. She's a 47-year-old female, housewife, studied up to 10th standard.
Krishna Mohan, be a bit loud. I think you may have to speak closer to the mic.
Okay, ma'am.
Remove this and speak the mic.
Am I audible now, madam?
Yes.
Coming to the case, a 47-year-old female, housewife, she studied up to 10th standard. She presented with chief complaints of behavioral changes for 5 years, cognitive disturbances for 3 years, sudden onset weakness of right upper and lower limb at 6 p.m. on 6th of December 2020, and worsening of slurring of speech on 21st of December 2020. Pre-morbidly, she is a very friendly and calm person and also was meticulous at household work. In 2016, first initially, the change in her personality was noted. It started as doubt of infidelity over her husband. She also had history of anger outbursts at trivial things. However, she used to calm down when husband used to talk to her, and this behavior persisted for 2 years without any significant worsening. In 2018, the suspicion about the husband has worsened, and there is more aggressive behavior in the form of beating the husband as well as breaking things when she gets angry. She became more inquisitive of the neighbors. She keeps scanning the neighbor's house for visitors, and also her interaction with the family members decreased. And she stopped going to family functions, and interactions with the family friends has also decreased. She also stopped watching television, and also her interest in other activities has decreased. Decreased expression of emotions was also noted. In 2019, the memory disturbances were noted initially. They were insidious in onset and progressive, and they are mostly episodic disturbances in the form of misplacing of objects, forgetting recent conversations, and she also sometimes forgets what she has eaten and she would ask for food again. She also forgets important dates and events. However, she is able to remember the old events and names. Sometimes she also used to forget to put off the stove, and sometimes she has burned the food also. Other cognitive disturbances in the form of difficulty in cooking, inappropriate cutting of vegetables, and also putting wrong ingredients while cooking was noted. These disturbances worsened so that she stopped cooking and she was unable to make even tea as before. And she had difficulty in taking bath and using soap and water also, leading to dependence on others for the ADLs. She also had urinary and fecal incontinence for a few months in 2020. There is no history of food faddism, obsessive or compulsive behavior, no history of difficulty in navigating between the rooms within the house, no confusion noted while wearing her slippers. She is able to dress without any difficulty. She did not have any difficulty in identifying the people. She used to understand whatever was spoken to her and reply appropriately. Her sleep and appetite were reported to be normal. On 6th of December 2020 at 6 p.m., while she was standing and conversing with her neighbor, she developed abrupt onset weakness of right upper and lower limb with slurring of speech, causing a fall over right side, leading to injury of the right upper limb and fracture of the forearm bones of the right upper limb. There is no loss of consciousness, altered sensorium, or seizures at the onset. Then at the local clinic, a POP cast was applied to the right arm and she was shifted to local hospital where she was admitted from 7th till 19th of that month. And she was evaluated with imaging and other workup. And she was discharged on dual antiplatelets and statin. At the time of discharge, she was bedbound. On 21st, while at home in the morning hours, the bystander noticed abrupt onset weakness, onset of facial deviation, along with severe slurring of speech such that her speech has become completely incomprehensible. And she also had swallowing difficulty. The bystander did not notice any limb weakness because the patient was bedridden. She was again taken to the local hospital where she was admitted for 1 week, and then she was shifted to our hospital on 31st of December 2020. She reached Sri Chitra Institute 10 days after the second event. Past history, there is no history of any joint pains, rash, dry eyes or dry mouth, recurrent oral ulcers, hair loss, headache. She did not have any history of recurrent abortions. She was detected to have hypertension 3 years back, but she was not started on any medication. There is no history of diabetes, dyslipidemia, coronary artery disease, prior stroke or TAA. There is no family history of young stroke or coronary artery disease. No history of any psychiatric illness in the family. To summarize, we have a 46-year-old female with untreated hypertension for 3 years, presenting with personality change, delusions of infidelity and apathy for 5 years, features suggestive of inattention, impaired recent memory and executive dysfunction for 3 years, social incontinence for few months, and sudden onset right hemiparesis with slurring of speech 3 weeks prior to the current admission, and worsening of speech for 1 week prior to the current admission. So with this history, we can localize the each disturbance to the corresponding region in the brain. Personality change can be localized to orbitofrontal cortex and its connections. Delusions of infidelity can be localized to dorsolateral prefrontal cortex, hippocampus, amygdala, and superior temporal gyrus. Apathy can be localized to mesial frontal lobe and its connections. Inattention to dorsolateral prefrontal cortex and its connections. Impaired recent memory to medial temporal.
Krishna Mohan, what happened between 2016 to 2019? Was the symptoms progressive?
From 2016 to 2019, initially for the first 2 years until 2018, she only had delusions of infidelity and some irritability. From 2018, she also had worsening of these behavioral changes, and from 2019, she developed executive dysfunction and inattention and memory disturbances.
Okay. So in that initial 2016 period, it was only minimal symptoms which are remaining the same.
Yes, ma'am. You are remaining same.
Okay. And then from 2019, there was a rapid worsening, more rapid worsening. Is
Yes,
that?
ma'am. Okay. Yes, ma'am. From 2016 till 2018, only she had the personality changes. From 2018, the personality changes worsened. And from 2019, she developed other cognitive disturbances.
Okay, you can continue.
The inattention can be localized to dorsolateral prefrontal cortex, impaired recent memory to medial temporal lobe, Papez circle and its connections, executive dysfunction to dorsolateral prefrontal cortex and its connections, the social incontinence to orbitofrontal cortex and its connections.
No,
The right
Krishna Mohan, inattention, you cannot tell like that. Inattention may be because of multiple reasons, no?
Yes, ma'am.
Okay, so you cannot tell that inattention because executive dysfunction understood, but inattention may be because of different reasons, no? Okay.
She developed right hemiparesis on 6th of December, which can be localized to left cerebral hemisphere at or above the level of pons. On 21st of December, she had worsening of dysarthria, which may be because of probably new stroke, which may be in either of the hemispheres. So to summarize,
No, why do you say, no. Why do you say worsening of the dysarthria, probably new stroke in either of the hemisphere?
Madam,
It has to be probably on the other hemisphere only, because you told the patient was able to comprehend, but there was a very severe dysarthria to the extent patient was almost anarthric, no?
Yes,
So
ma'am.
suggesting there is a bihemispheric involvement. So we can definitely say there is a bihemispheric involvement.
Okay. So the patient had frontal and medial temporal involvement and 2 episodes of probable stroke. So the clinical possibilities considered were systemic vasculitis with CNS involvement. Because of the patient, she's a middle-aged female presenting with neuropsychiatric symptoms, followed by 2 episodes of stroke. So this was even in the absence of systemic symptoms, the systemic vasculitis being common, it was considered first. Then vascular dementia, and then primary CNS angiitis. So primary CNS angiitis, in the absence of the systemic features, it is likely, but usually the course of this patient, that is patient remaining stable for many years without worsening, is unlikely for primary CNS angiitis. In view of her age, inherited cerebral small vessel diseases like CADASIL, and also MELAS need to be considered, but absence of family history is against this point. Chronic infection-related vasculitis like HIV also need to be considered, though rare. Very unlikely, but to dissociate between the psychiatric symptoms and the stroke, a primary psychiatric disease with recurrent stroke due to poorly controlled vascular risk factors may also be considered as last option.
So if
On
you take off
examination
the Krishna Mohan, if you take off the that 5 years, no?
Yes,
So still along with these differential, always a malignancy, especially like intravascular lymphoma, and those entities should also be considered. But definitely, as you mentioned, 5 years is a duration is slightly longer for a patient who is having
Malignancy.
vascular lymphoma, because that is a
Mohan,
differential for these conditions.
Dr. Shalja, I mean, why we are
Yes.
putting all vascular differential diagnosis? Can't we entertain any other non-vascular
Yes, definitely, sir.
disorders? Yeah.
Krishna Mohan? What
And
are the other non-vascular pathologies you will consider in this background? Why did you consider only vascular pathology, vascular causes in this condition?
Madam, the other causes like autoimmune encephalitis for such a long period, it is unusual. And also demyelinating diseases is unlikely to present with neuropsychiatric manifestations followed by sudden onset hemiparesis. So
Any other
considering these,
possibilities, Naveen?
The only odd points were the long duration of symptoms for 5 years, and patient had 2 episodes of stroke, which was definite from the history. There was a stepwise decline in at least 2 episodes that favors a vascular etiology. So
Can we still consider, because of the longer duration, the vascular events only recently?
Indolent, slowly progressive neoplastic lesions can be considered, but it is very unlikely to remain confined to the CNS and not having any other spread. That is one against the other possibility. Second, autoimmune and paraneoplastic entities also can have this, especially paraneoplastic forms can have CNS presentation. But then again, usually paraneoplastic entities will be diagnosed within 4 years prior to malignancy. And entity running longer than that is considered unlikely for a paraneoplastic encephalomyelitis or encephalitis for that matter. So that is why we did not consider other possibilities in this patient upfront.
Oh, I think it should come up as a differential,
Yes.
at least, psychiatry to start with, maybe a different phenomena. That way also you can differentiate. Also, ongoing neurodegenerative disorders also come into mind, genetic disorders. So I think you should, at this
Yes.
juncture of time, you should have
Yes.
a wider differential diagnosis. And those stroke-like episodes, I don't think they were very clear-cut stroke as per the history. There's a high possibility that they were stroke-like, but I mean, you need to confirm on imaging, etc. I think.
I fully agree, sir.
Hmm.
And there are a lot of oddities for this also.
Yeah, absolutely.
Yes.
Absolutely. Thank you.
Proceeding with the examination, at admission, her blood pressure was 184/96, and she had a heart rate of 69, and her pulse was regular. And the systemic examination of cardiovascular system, respiratory system, and abdomen were normal. The general examination was also unremarkable. Coming to the neurological examination, she was conscious, oriented. She had normal comprehension, normal word output, and she also had spastic dysarthria. Her MMSE was 14/28. She lost predominantly 5 points in attention. Her higher mental function evaluation following this was confounded by inattention. She had writing construction could not be assessed due to fracture of the right forearm. She lost 5 points in orientation to time, 2 points in orientation to place, and 2 points in recall. Because of the inattention, the patient was tested whenever she was able to she is able to cooperate and perform the test. The frontal function showed that insight is absent, judgment and similarity recognition is impaired, abstract thinking is impaired, forward digit span is 3, backward digit span is nil, and on random A test she had errors of omission, and lexical fluency is 1 and category fluency is 3. The motor programming go, no go, and fist edge palm test were impaired. Trail making and drawing alternate sequences could not be tested because of the fracture of the right arm. The temporal evaluation showed recent memory impairment. The occipital and the parietal lobe function tests were normal. So the lobar function test examination showed predominant frontotemporal dysfunction. And the cranial examination showed right human facial palsy. Motor examination showed spasticity of all the 4 limbs. And she also had weakness of right upper and lower limb and also left lower limb. She had hyperreflexia and plantar on both sides is equivocal.
Bilateral lower limb.
Yes, ma'am.
Okay. And spasticity of all 4 limbs. Just show that. Okay.
Yes, ma'am. She has spasticity of all 4 limbs. She had 2 strokes, ma'am. First on the, she had developed right hemiparesis, and following that she had dysarthria. At which time they did not notice the left lower limb weakness in the history.
Okay.
She had ataxia of all the 3 limbs, and right upper limb could not be tested. And her NHS score was 10 and MRS is 4.
Sensory, how could you examine? You told it was very difficult to get her attention. How can you say it is normal? Are you sure?
Like when she cooperated, we tested, madam. Grossly, there is no sensory abnormality is not found.
Okay.
So to summarize, she had cognitive dysfunction, predominantly frontotemporal involvement, and she also had bipyramidal involvement.
What about the Georgia?
When Georgia is also brisk, madam.
Was brisk.
Yes, madam.
Okay, accelerate. Okay.
So to summarize, she had cognitive dysfunction, predominantly frontotemporal involvement, and also she had bipyramidal involvement.
And you told there was some cerebellar involvement also?
Yes, ma'am. She also had ataxia also. But she did not have she did not have other cerebellar signs except the finger nose coordination, incoordination.
On the left side?
Yes, ma'am.
Okay. So what's your localization here? Frontotemporal and then bipyramidal involvement, and also there is a cerebellar involvement also.
Yes, ma'am. Also cerebellar involvement is there.
Okay, so where do you localize now?
No, the localization is to the diffuse frontotemporal
There is
involvement,
cortical involvement and subcortical
and
involvement,
subcortical involvement is also there.
both cortical and subcortical involvement.
Yes, ma'am. So now, after the examination, we can rule out the primary psychiatric disease, and the remaining clinical possibilities remain same, that is systemic vasculitis with CNS involvement, vascular dementia, primary CNS angiitis, inherited cerebral small vessel disease, and chronic infection-related vasculitis.
Inherited cerebral small vessel disease, which ones?
CADASIL or MELAS can be considered.
MELAS. Navi? Yes. Mitochondrial disorders then?
CADASIL, and if it is in male, we can consider Fabry's disease also. And collagen mutation, collagen 4 related mutation disease can also be considered. It's a rare entity.
But Fabry's usually most of the time, what is the features of Fabry's? Fabry's.
Fabry's
Navi?
male patients X-linked disease with acroparesthesia, angiokeratomas they will have, and that
Yes.
is usually found in Fabry's.
And most of the time it is subcortical, small vessel vasculitis rather than this kind of such a severe cognitive impairment in the onset is very, very unusual. So as you told, it can be an ABRA, amyloid related vasculitis that can happen like this, and then other inherited like CADASIL and all can present initially with cognitive and then can have recurrent strokes and a rapid cognitive impairment.
Another thing, sorry, Dr. Salja, to interfere, this chronic infection related vasculitis. I mean, chronic meningoencephalitis can also have like neurosyphilis
Yes.
or maybe HIV also.
Yes.
I think this vasculitis word at this juncture is, I mean, sorry, but it
Yes.
really, we have a lot of other Hashimoto's, for example, or even chronic celiac, these, that, so many things we have to keep in
Yes.
mind.
Yes.
Sure.
Yes. But especially the chronic infections, what is like HIV, syphilis, those are the ones which we need to consider because tuberculosis and all is less likely to produce this kind of a presentation. And as Sir has rightly pointed out, other possibilities like Hashimoto's, but only problem is that with regard to those, predominantly it has gone into an early phase of having significantly rapid decline of cognitive with stroke-like presentation. So that comes lower down, but still that needs to be considered. Yes.
I entirely, but as this class is for the dissection and spirit to
Yes.
train the
Yes, yes,
student,
sir.
I
Yes.
think it's our duty to, make a wider vision at this point of time.
Yes, I fully agree, sir. What else? What else you want to consider?
No, that's fine. I mean, just
Yes.
again,
Yes. Yes, I
for-
think I
food
think
for thought.
wider. Yes, it's always better to think widely and then come to your differential and tell about all the odd points for each of the differential diagnosis. No. In these patients, probably especially if that stroke-like episodes were not there, most of the other cognitive impairment, the causes of rapid worsening of cognitive decline should be higher up in your differential.
Yeah.
For example,
No,
all of those comes higher up, but still in this situation, maybe stroke may be totally unrelated also in a patient, no? Especially if you have a hypertension for a long period of time, it may be partly related to the other vascular risk factors too.
Yeah. So basically, you may be right that ultimately it may turn out to be primary CNS anxieties or similar, but we have to see, how beautifully he has given the different symptomatology, and based on that, the deduction should be very logistic and slow and simple. That is what, and very stepwise.
Okay, so I fully agree.
Please go ahead. Please go ahead.
Coming to the investigations, the routine blood investigations, including CBC, RFT, LFT, HbA1c, lipid profile, were all within normal limits. Her ESR and CRP were elevated, but at the time of admission, she had UTI. Her systemic vasculitic evaluation, including ANA, showed 1+, ANA profile and other vasculitic markers were negative. Her 2D echo and ECG were normal. CSF study showed sugar of 67 against a blood sugar of 104, protein of 32, and 2 cells there and 100% lymphocytes. CSF culture showed no growth. CSF TB PCR was negative, and CSF India ink preparation was also negative. This is the first MRI done at outside hospital at the presentation of right hemiparesis on 7th of December 2020. Here we in the diffusion imaging we can see an acute infarct present in the left corner radiata and also in the posterior limb of the internal capsule on the left side. This is T2 flare images of the patient showing extensive white matter hyperintensities. That is grade 3 Faseca changes are present. And also we can see that the white matter changes are also involving the anterior temporal lobe and also in the external capsule and also involving the brainstem and the middle cerebellar peduncle and into cerebellum also. Also, we can see some cerebral atrophy is also seen. This is the contrast images of the
Can you show that image once again, Krishna Mohan? What are the other findings?
Here we can see grade 3 Faseca changes are present. And also there is diffuse cerebral atrophy is seen. And the white matter hyperintensities are also present in the anterior temporal lobe and the brainstem also.
Okay, yeah. So that's an important finding. So that is another thing you have to look for.
And also in the external capsule also.
Okay.
The contrast images did not show any leptomeningeal or parenchymal enhancement is not seen. The gradient images showed multiple microbleeds, both cortical as well as subcortical, diffusely throughout the brain, including the in the posterior fossa also.
So what is important to mention there in the microbleeds?
Both cortical as well as subcortical microbleeds are present. And they're diffuse.
Else? So what is the, even though it is present, cortical and subcortical is present, we are seeing a it's almost equal. So
Yes,
that is also important. When you, the distribution of the microbleeds, when you are seeing also, no, if even though you see both cortical and subcortical, when the cortical is significantly more than the subcortical, that takes you to other etiologies compared to predominant. If you see here, predominantly it is more of subcortical microbleeds compared to the, but lobar is also there definitely, but it is less compared to the subcortical ones.
When she had worsening dysarthria in 24, repeated diffusion showed an acute infarct in the right thalamus. And once the patient is admitted to our hospital, repeat imaging was done. The diffusion at this point of time did not show any acute infarcts. The T2 flare showed the same findings, that is the grade 3 Faseca changes, cerebral atrophy, and anterior temporal involvement and the external capsule involvement. This VAN imaging done at our institute also showed the microbleeds more clearly, and they are more extensive. Both cerebral as well as the subcortical microbleeds are present. They're also present in the posterior fossa in the cerebellum and also in the brainstem. So the MRI differentials for are primary CNS angiitis and CNS vasculitis secondary to systemic vasculitis because of the multi-territorial infarcts, grade 3 small vessel ischemic changes, and multiple microbleeds. The points favoring for cadacil are diffuse small vessel changes, multiple lacunar infarcts, anterior temporal lobe involvement, that is O'Sullivan sign, and external capsule involvement. The points favoring the amyloid beta related angiitis are diffuse cerebral microbleeds.
Thank you, Krishna Mohan. Now we'll proceed to the DSA of this patient. So based on this MRI, we found a few differentials which we had in mind. So this patient cadacil is
Naveen, you have to be a bit loud. I think speak closer to the mic.
So based on this imaging, we have the leading differentials as a vasculitis secondary to systemic or the primary CNS vasculitis versus a cadacil or an A beta related angiitis. Because this form of multi-territorial infarcts, diffuse microbleeds, grade 3 Faseca changes are most commonly seen in these conditions. So we want to proceed with the DSA to look up for any angiographic abnormalities which suggest any of these. So in the DSA, we are able to see multiple areas of luminal irregularity as seen in that. This is a right ICA injection where we are seeing in the right ACA territory as well as the PCA territory. This is through the PCOM, the PCA posterior circulation is being filled. Multiple areas of luminal narrowing and ectasia is seen. And we are able to appreciate in this PCOM, bilateral PCA, right ACA, as well as the distal branches of the MCA also. So all these, this kind of MRI, this is in the right IC injection. Now we go to the left IC injection. Again, we are seeing areas of narrowing followed by dilatation. This is the typical sting on bead appearance which we are seeing. This is the left vertebral artery injection showing bilateral PCS which are throughout irregular as well as ectatic. Areas of narrowing followed by dilatation is seen. So this kind of angiographic picture gives a differentials as vasculitis versus an intracranial atherosclerosis. So both these.
So what are all the differential diagnoses? Naveen, what are all the differential diagnoses? This kind of an angiographic picture.
RCVS, reversible cerebral vasoconstriction syndrome, vasculitis, intracranial atherosclerosis. These are the reading differentials for this kind of an angiographic appearance. This can also occur with multiple embolic shower secondary to an atrial myxoma also can occur, but this involvement of distal vessels is less likely. With regard to RCVS versus vasculitis, RCVS most commonly involves symmetrical bilateral proximal segments of the M1 MCA, A1 ACA as well as the distal ICA when compared to vasculitis which involves the distal small cortical branches as well as the MCA branches. Second, intracranial atherosclerosis can have same angiographic appearance which cannot be differentiated only based on DSA alone. So in this patient, since we are having multiple other...
Why can't this be intracranial atherosclerotic disease also? Because this patient has got a hypertension. This patient has got grade 3 small vessel ischemic changes. And the MRI and the angio is showing this finding. The same picture can occur with the intracranial atherosclerotic disease also.
Yes, they will usually have proximal vessel calcifications also. And
only point which is against, it can still happen. Some patients can have a predominantly intracranial atherosclerotic disease also. But the point favoring more likely vasculitis, maybe one is this picture of dilatation. This picture of stenosis followed by significant dilatation is very unusual for a atherosclerotic disease. Second is the rest of the large vessels is not showing any evidence of atherosclerotic disease. Those are the points we can take as, because otherwise the same picture can occur in patients with intracranial atherosclerotic disease.
Proximal vessel calcifications are all close for an atherosclerotic etiology. So in this patient where we had a diagnostic dilemma, we had proceeded with a meningocortical biopsy that did not show any evidence of vasculitis. And since CADASIL was also in the differential diagnosis, we had to do a skin biopsy which was negative for any osmophilic granules. The patient was not available for genetic testing for the same. So in patients who are having an angiography positive but a negative biopsy, there is an added utility of high resolution vessel wall imaging which we have in our institute. Here we are able to, this involves a contrast administration, and we are able to demonstrate concentric thickening and grade 2 enhancement of multiple intracranial vessels, which are seen predominantly in the basilar artery, as well as bilateral intracranial ICA in the supracranial portion we can see here, as well as bilateral PCA territories we are able to see, as well as the last image showing left M1 MCA in the sagittal plane also. All are showing we can see a concentric thickening as well as grade 2 enhancement. This enhancement pattern comes with the comparison based on the enhancement of pituitary infundibulum. Grade 0 is less, no enhancement. Grade 1 is enhancement compared to the less than the pituitary infundibulum. Grade 2 is equal to or more than the enhancement of the pituitary infundibulum. So this is a point which is favoring vasculitis over other etiologies. The presence of a juxtaluminal T2 hyperintensity with the surrounding hypointensity would have favored an intracranial atherosclerosis in this patient over and above the vasculitis, which was not seen in our patient. The other differentials which can occur with, although this angiography picture was not suggestive, was a Moya-Moya disease, but however, we did not find any evidence for Moya-Moya in our angiogram. So coming to Calabrese and Mallax criteria, a patient is suspected to have primary sinus meningitis, should have otherwise unexplained neurological or psychiatric deficits, either classical angiography or histopathological features to suggest the same, and no evidence of systemic vasculitis or any other disorder which could account for these features. And our patient had fulfilled all three criteria, and we had diagnosed the patient to have a primary angiitis of CNS based on this. Since we have reasonably ruled out all other differential diagnosis, and the patient fulfilled the criteria. So,
excuse me, 1 second, please. What is the CSF finding? Could you please show it?
CSF finding was normal, sir, actually. Just a minute.
Okay.
This is the CSF finding. 32 protein, sugar was 67, and 2 cells were there. With the CSF culture, DVPCR, CSF India in preparation were negative. We are also sent other pan-fungal antigen assays which were negative, and we did not find any other systemic vasculitis profile which was positive in this patient. So, Paran sir, your voice is muted actually. Yes.
If you are suspecting primary CNS angiitis ultimately,
Yes, sir.
we
We did not find any other secondary causes or systemic vasculitis to account for that. And,
what is the normally CSF finding in? Would you expect some abnormality in
We are
CNS vasculitis?
elevated protein, and pilocytosis is less often expected. No hypoglycemia should occur, and protein should usually elevated. But this CSF finding of elevated protein can occur in 70 to 80% of the patients.
So what's can you get a CSF finding like this in primary CNS
Yes,
angiitis?
when the patient is not, this is only a clue to give that is an active CNS inflammation is going on. The patient, when he had come to us, CSF can be normal also, even in 20 to 40% of the patients with the primary CNS angiitis.
But more, at least about 50 to 60% of them, at least a mild elevation of mild to moderate elevation of protein can occur in them. Only thing, the sugar will be normal in these patients.
So this patient, based on the diagnosis of primary CNS vasculitis, we had treated her with 5 days of IV methylprednisolone followed by first dose of cyclophosphamide was planned, which was however deferred in view of her UTI. She was given oral steroids and discharged. And at discharge, she was having a residual right upper limb and lower limb bar of 3/5 with the left lower limb drift and upper and lower limb ataxia on the left. So the patient received 2 monthly doses of cyclophosphamide later. And this was stopped subsequently in view of pancytopenia, and she was switched over to azathioprine and prednisolone, which was being continued in a tapering dose. At 1.5 years follow-up in June 2022, she had no further strokes, was ambulant with 1% support. Her psychiatric symptoms had significantly improved, and there was no further cognitive decline. She is being continued currently on azathioprine and oral steroids on tapering doses. So, briefly summarize to tell a patient with a subacute cognitive impairment, recurrent focal neurological deficit, new onset or modified headache, and ischemic stroke, seizures, subacute encephalopathy, all these are pointers to suspect a primary CNS vasculitis, which is corroborated by strong supportive imaging findings like multiple micropleas, diffuse small vessel ischemic changes, and angiographic showing multiple areas of narrowing followed by dilatation. So if these features are there, we could suspect a primary CNS angiitis in this patient. World over.
I think, Naveen, we will not have time for more discussing because it's already 3. We have to leave some time for questions. So, shall we stop and go for the questions, sir?
I think Naveen, if you can finish in next 5 minutes is fine enough. Then
Okay.
We had some beautiful things to show, but give the gist of the things. And before I say anything, I mean, did you please answer a query? Have you done NOT3 in this case or not?
Which one, sir? We could not do, sir. Genetic testing we could not do because patient was not affordable. We did a skin biopsy, which was negative for osmophilic granules.
Okay, all right.
So to briefly summarizing, if you have a clinical history examination with positive MRI, you can, and after reasonable exclusion of systemic vasculitis or other diseases, then we have to classify them whether there's a suggestive involvement of large and medium vessels by angiography or a suspected involvement of small vessels. So large vessel and medium vessel involvement will usually present with recurrent strokes with focal or hemiparesis kind of presentation. Focal neurological deficit is the most common presentation. whereas small vessel involvement usually presents with a subacute cognitive decline, psychiatric manifestations, and seizures, who are often missed by DSA and picked up by a biopsy. So the treatment I have already covered, but this is the institutional treatment protocol, which I would like to show. We classify patients as mild and moderate to severe disease severity based on their deficits as well as the MRS at presentation. If there's no large vessel involvement and the patient is having slow progression, we can categorize them as mild, and moderate to severe with the NHS more than or equal to 5, large vessel involvement, bilateral multiple infarcts, and rapid progression as moderate to severe disease activity. In those with mild, we prefer to give a methylprednisolone 1 gram per day followed by oral steroids, and later switch them over to a steroid sparing agent like azathioprine or mycophenolate mofetil, and continue them on maintenance therapy, and de-escalate them once the treatment of duration of at least 1.5 to 2 years, if without any clinical or radiological relapse has been maintained. In those who have a aggressive disease course, we prefer to give an aggressive upfront induction therapy with IV methylprednisolone followed by cyclophosphamide monthly pulse injections, followed by a maintenance. This pulse continues for 6 months, followed by switching over to an alternative immunomodulatory agent like azathioprine or MMF, and then de-escalation like the preceding manner. There is a subset who have continued to be refractory even with the IV methylprednisolone as well as cyclophosphamide therapy. Despite giving the best aggressive medical management, they continue to have relapse or worsening clinical status. In those patients, we consider second-line agents like rituximab, or alternative agents like infliximab and etanercept can be attempted. There is now data available for infliximab, etanercept, as well as newer drug. Next drug on the horizon is the IL-17 antagonist blockers like secukinumab also, which is coming up.
Okay.
Thank you.
I think it was a good presentation, Krishna Mohan and Naveen. A few points which I would like to say is that this case was shown mostly with the intention of thinking about the possibility of this entity of primary CNS angiitis, mostly because this is one of the diagnoses which is many a time missed in these patients. And we think about other possibilities, and unless you do meticulously angiogram and biopsy, even if the angiogram is negative, in these kind of small vessel, significant small vessel vasculitis is present, it is important to do biopsy because even the angiogram can be negative in these patients. Second is always we need to consider this early in the diagnosis. But most of the odd points in this patient is there was no history of any headache. So many a time headache may be present in only about 60 to 70% of these patients. And other causes of cognitive dysfunction needs to be considered before we finally, because these are all entities which are treatable and we need to consider them early in the diagnosis. Even when we looked at our series of primary CNS angiitis, the delay in the diagnosis was to the tune of 6 months to 12 months. So it's very important to consider them early in the diagnosis. And more important now is that angiogram is mandatory for these patients. And in this patient, actually looking at the anterior temporal involvement, the possibility of a CADASIL was very high. Only when we found that the angiogram was showing the classical features of vasculitis, we considered that to be more likely, but otherwise the imaging picture with the small vessel changes, microbleeds, and the anterior temporal involvement, the CADASIL is still high in the cards in this patient. Are there any questions? So can cerebral amyloid angiopathy be kept in the differential diagnosis? Definitely. So this is a setting where you will definitely consider the possibility of a cerebral amyloid angiopathy. But few points to be considered here are that these patients with the cerebral amyloid angiopathy, most of the time in them, the microbleed pattern is more different. They have more of significant lobar microbleeds compared to subcortical microbleeds compared to the other entity of primary CNS meningitis. And cerebral amyloid angiopathy, by the time these patients have this much amount of worsening, most of the time they will have superficial siderosis also in them. So definitely otherwise cerebral amyloid angiopathy, and that is why we initially told about the possibility of a amyloid related angiitis. which is closely a differential diagnosis in these patients. And there also it is important to do a biopsy in this patient. That is the only way you are likely to pick them up. And also you need to do specialized stains in them to pick up this entity. CJD, the possibility of CJD was just less likely in this patient because the patient presented to us almost 3-4 years later. That is why, otherwise if the patient has presented to us very early, definitely for a rapidly worsening dementia, CJD would have been considered. But this patient was a prolonged long history, so less likely, and also with the presence of multiple strokes. So the next question is, why was the patient worked up so much? Why wasn't the patient labeled as a mixed dementia? I wish to ask, what are the red flags where we should do so much workup? Okay, very good question. So if a patient, whenever a patient is presenting with a dementia, definitely the rest of the features becomes very important. So here in this patient, by the time the patient presented to us, the patient has had significant bipyramidal findings, and the patient has had a multiple stroke-like presentation. But still, as we have already mentioned, it can be a vascular dementia with an associated other dementing illness. The red flags in this patient was mostly related to the, when you see so much of severity of white matter changes, even while in a very short period, the patient getting recurrent strokes, we need to definitely consider that it's a red flag. Second is, if the patient has got a history of headache in the presence of this dementing illness with a grade 3 significant small vessel ischemic changes, that is also a feature to suggest a possible more detailed workup. Here, there was a need of workup in the form of DSA and all was considered, because we have got by the time the patient came to us already, there was a stroke, and the presence of small vessel changes suggests there is a small vessel vasculitis in this patient. So in this patient, there was a definite need to work up further, because dementia needs workup with all the infective causes. We need to definitely rule out all the reversible causes of dementia in this patient. Can we say primary CNS angiitis even in the presence of hypertensive changes elsewhere in the body, like concentric LVH and grade 1 diastolic dysfunction? Definitely. So primary CNS angiitis is a diagnosis where it is made not with a single point. Here, the primary, this patient, a hypertensive patient, can have small vessel ischemic changes. But if you look at the small vessel ischemic changes in this patient who is a 50-year-old, what is the age of the patient? 50. What was the age, Krishnamurthy?
47, madam.
So 47. For a patient with a 47-year-old with so much of small vessel ischemic changes, it is difficult to explain with hypertension alone. So definitely we need to consider there is other cause of, so small vessel ischemic changes can occur as a part of renal dysfunction. It may be part of age related, but whenever you have just a hypertension alone, that cannot explain the severity of the white matter changes in this patient. Biopsy is negative for vasculitis. Yes, definitely. If you look at the primary CNS angiitis series, you find that the biopsy can be negative in about 40 to 60% of the patients. So biopsy negativity happens most often in the large vessel vasculitis patient, and it is more likely to be positive in the small vessel vasculitis. And also it depends upon whether you do a targeted biopsy in this patient, especially in the areas of leptomeningeal enhancement. When to do brain biopsy and what sites have a better yield? When to do brain biopsy, if you are suspecting the possibility of a primary CNS angiitis, or the biopsy is not only for primary CNS angiitis. As we have discussed, there are a lot of secondary chronic conditions, especially like syphilis, malignancy. All these can produce a vasculitic presentation. So infective vasculitis, malignancy can also have a similar presentation. So brain biopsy is done mostly to confirm the diagnosis of primary angiitis to give definitely treatment. Second is to rule out other secondary causes of vasculitis, which can be malignancy or other infections, and even amyloid-related vasculitis. If you look at the yield of biopsy, you find that many a time by biopsy, you may get definitely alternative diagnosis. It can be an infective cause. So it's very important to do a brain biopsy, and especially when you are when you have a CSF showing elevated protein, even if there is a mild to moderate pleocytosis, even in the presence of the sugar not being low, still it is important to do a brain biopsy and rule out secondary causes of vasculitis, because as you know, immunosuppressive treatment is risky in a situation of infective causes. Any role for antiplatelet or anticoagulation in acute stroke with primary CNS? Definitely there is no role. The treatment is immunomodulatory treatment and immunosuppressive treatment. Is thrombolysis safe? There is no data on thrombolysis in primary CNS angiitis, but I would say thrombolysis is not safe in these patients because primary CNS angiitis, one of the presentations, they can present with small aneurysms, and it may be risky to give thrombolysis to these patients once it is a diagnosed case of a primary CNS angiitis. How to differentiate HIV dementia and CADASIL in the MRI brain? I really do not know HIV dementia, how you differentiate in the MRI brain, but CADASIL, as you have seen in the MRI, significant small vessel changes, the presence of anterior temporal involvement, and also the presence of the microbleeds, mostly in the lobar territory with studded microbleeds are features to suggest an MRI. But how to differentiate the HIV dementia, I am not sure, we may have to look up. Pickup rate of vasculitis, CTA versus DSA patient. Definitely, this is one situation where DSA becomes mandatory in the diagnostic. You cannot stop with CT angiogram or MR angiogram. Any patient you are suspecting a vasculitis, you have to do a DSA because of two reasons. One is many of the, even with CT angiogram, the small vessel vasculitis pickup is not possible with the CT angiogram. So you need a DSA to definitely diagnose them. And with regard to the MRI also, the same problem of the distal resolution of the distal vessels becomes difficult. And knowing about the presence of both, whether it is medium, small, and larger vessels is also will help you to prognosticate and decide on your treatment. Secondary vasculitis, secondary to systemic vasculitis, definitely the management will be similar to the systemic vasculitis, especially if you have a secondary vasculitis, which can be, secondary vasculitis may be part of a infective vasculitis, or it may be part of the other connective tissue disorders, or it may be part of a vasculitis, which can also be secondary to other chronic infections. Can small vessel ischemic disease explain all the symptoms? The small vessel ischemic disease can occur in patients with, because of the hypertension, renal dysfunction, and it may be related to the age, but all this cannot explain the rapid progression of the symptoms in this patient. This patient had a very significant psychiatric symptoms, significant cognitive decline with recurrent strokes. That cannot be explained by just a small vessel ischemic changes alone to explain this. So I think we have already, can we stop? Probably we can answer these questions over email.
Yeah, I think we should call it a day now. And thank you. Rest of the questions, Dr. Heli, kindly send Erin to send all those questions to ma'am and her team. I must really congratulate and thank team of Suchitra and particularly Madam Dr. Shalja and of course all the residents and the assistant professor and the fellow who have all done wonderful work, very nice presentation, wonderful discussion, nice localization, good differential, and also nice discussion of the diagnosis. How can we thank enough? But ma'am, this was really an eye-opener and a nice training class for students. The wonderful way of investigating stroke neurology, the radiology part particularly, it was very fascinating, and we are very thankful for your time and your participation. Once again, on behalf of the team of Secrets of Neurology and my colleague, Professor Narsim, who is not today somehow for some reason. So on behalf of our team and all the delegates, we are very thankful to you. And the closing line, I would like to thank all the students and all delegates, which are not only from India, but as I've been repeatedly telling you, they are coming all across the globe. Somebody from Canada, Spain, UK, Japan. I see somebody from Thailand, I see Nepal, Pakistan, and some other countries. So we are very excited, and we feel quite gratified and satisfied also that this series is going strong. And we will like to continue as long as you people take so much interest. Thank you for your questions also, which are very valid and very interesting questions. And lastly, again, I am thankful to Team Intas Globusel, headed by Mr. Chadda and the team. With that, I hand over mic to Mr. Chadda for his Thanksgiving.
Thank you, sir. I would like to thank you, sir, for the opportunity to have our team present for today. And it was great to be part of this interesting session. And thanks to the Intas team too for making this educational event, which would be so. In fact, it's more encouraging and more educative to the residents. And I'm really happy that there were a lot of questions, and sorry, we could not go through the whole questions because it's already 10 o'clock. We were supposed to finish at 9:30. So I think any of the questions you can send it to Haley so that we can answer them. And thanks to the whole team for being part of this event. And thanks to my dear residents and fellow who had put all their effort in bringing out this presentation. Thank you.
Thank you, Madam.
Thank you, ma'am. And today it's really a great day that we are at the end of 26th session of Secret of Neurology, which is the longest web series till date. And we are very sorry that we have shifted this program from the last Friday to today because of some unavoidable circumstances. I, Arun Chadda, Associate Vice President on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 25 months. It's audience like you that makes presentation awesome. Thank you very much for your unwavering attention throughout the presentation. And I would like to thank our Honorable Course Director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. We are very thankful to young neurologist Dr. Manisha and Dr. S.M. Krishnan for presenting the excellent unique cases. Further to this, I would like to thank Dr. Naveen Kumar Singh for presenting the differential case investigations and case analysis. And I am very grateful and thankful to Professor Dr. P.N. Shalja ma'am, Head of the Department of Neurology, Shri Chitra, Tirunal Institute of Medical Sciences and Technology, Trivandrum, for case analysis and for providing the important learning points and proceeding of the unique cases of stroke. The entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for your gracious presence. And it's being a pleasure being with all of you today. Thank you all for your patience. And I wish you all very good night in this month. And we'll meet again on 30th September next month with yet another most awaited next session of Secret of Neurology. Till then, stay safe and stay healthy. Thank you. Thank you, Emma. Thank you, ma'am.
Thank you.
And
ma'am.
thank you all. Thank you, sir.
Thank you, ma'am. Thank you, sir.
Thank you, ma'am. Thank you.
Rohit, we can end. Bye, sir.
Bye. Bye. Thank you. Thank